I am that nursing prof and welcome to my channel. In today's video, we're going to be discussing how to read a fetal heart rate monitor. So let's jump into it. The first things we need to know are the normal things. So the baseline. So baby's baseline fetal heart rate should be between 110 and 160 beats per minute. Variability refers to any change from this baseline. And then there's three types of variability. There's normal variations, where the heart rate can go up or down 60 to 25 beats per minute. We would prefer up. There's moderate variability, which goes over 25 beats per minute. And then the third type of variability is actually a loss of variability, so where we don't see any, where it is a flat line. Just like in adults, right? When we look at an EKG on an adult, what do we like? Squiggles, right? We like squiggle lines. We don't like flat lines. Flat lines are bad. Same for baby, okay? So a loss of variability, a flat line, that's no good for baby. We like variable, squiggles. So there's reassuring and non-reassuring fetal heart rates. So a reassuring one is within that range, that 110 to 160. There are increases from the baseline, so like our normal or moderate, and there should be no decreases. Non-reassuring is when the baby is showing tachycardia, so greater than 160, bradycardia, so less than 110, several decreases from the baseline, an irregular rhythm, or decreases within 30 seconds after a contraction. And CTX, that's just a little shorthand for contraction, in case you were wondering. So if we look at our sample grid here, I am not an artist, I know, I'm sorry, but I tried to do my best. This is how it's set up. So it goes up for beats per minute in intervals of 30, so 60, 90, 120, 50, etc. So each of these little boxes represents 30 beats per minute. Each of these little boxes represents 10 seconds. And then I tried to draw the lines darker so you could tell. So from this dark line here to this dark line here, this is 1 minute. So 60 seconds, so 10-second intervals here for 1 full minute. And that's what our grid looks like. And if you can tell, I tried to use the same color so you could tell, this is a reassuring pattern since we have our squiggle lines, right? We have variations from our baseline. That's a good thing. Okay, now let's talk about some variations. Bradycardia is when baby's heart rate is 110 or less for greater than or equal to 10 minutes. Some causes of bradycardia can include anything that has to do with poor oxygenation to the baby. So maybe mom's a smoker, she has high blood pressure, maybe she's overdue and her placenta is starting to calcify. So anything that's going to cause a lack of oxygen to the baby is going to cause bradycardia. Tachycardia is greater than 160 and it's still that 10-minute mark. So it has to be greater than or equal to 10 minutes long for it to be considered tachycardia. Usually the cause of tachycardia is infection. So if you're watching mom, you're taking care of mom and she's in labor and you start to see that heart rate on baby go up, up, up and it stays there, you want to go take mom's temperature right away. Because tachycardia on a baby, you automatically want to think infection, like choreo or something like that. Some good things that can happen are acelerations and early decelerations. So an acceleration, this is a really good thing. This means baby's moving around, they're wiggling around in there. So an acceleration is an increase in baby's heart rate by 15 beats per minute at least, it could be more, and that has to last at least 15 seconds and can last up to 2 minutes. Sometimes we call these 15 by 15s. So an increase in fetal heart rate by 15 beats, lasting for at least 15 seconds. And then here's my terrible drawing of this. I know, I'm sorry, I'm not an artist. I'm just trying to make this the best I can. So here's baby's heart rate up here, and then I didn't even draw the grid for the contractions because I know it wasn't going to look good. So here's our contractions. So baby's heart rate, you see it has variability. It's reassuring, right, from baseline, and then it goes up. It goes up at least 15, and actually this one goes up almost 30. So reassuring, and then we have our acceleration, which is an increase from baseline at least 15 beats and lasting at least 15 seconds. So accelerations are good things. When do accelerations happen? Usually when baby's wiggling around, they're changing position. Maybe you, the nurse, have just done a vaginal exam, you've pressed the baby's head, and it's kind of responded like, whoa, what are you doing? So when it gets up and moves around. Maybe you've done some vibroacoustic stimulation, you've taken the little buzzer and like, buzzed mom's belly and woo, woke up baby, right? All of those are reasons babies can have acelerations. Acelerations are a good thing. We like those. Decelerations. So there's 3 different types. We're going to talk about all 3. I wanted to start with the good one first, and that's earlies. So an early deceleration is a decrease in fetal heart rate that starts when the contraction starts and ends when the contraction ends. These should never go below 110 beats per minute. So they're going to stay within our normal range of 110 to 160. So if you can see what I drew here, here are contractions and then here are earlies. So you see how they kind of mirror the contractions? So they start when the contraction starts and end when the contraction ends. And I kind of drew a little dotted line down. That's something you can do when you're learning fetal heart rates. If you have a strip in front of you, draw on it. Draw your little line down and see, okay, where is the nadir, so the bottom part of the fetal heart rate, to the acme, which is the strongest, the peak of the contraction. So draw a little line down and see where do they match up. Do they match up? If they do, if they're mirror images of each other, then these are earlies. Earlies are good. Earlies make sense. Earlies usually happen when mom is getting ready to push. So early decelerations are a good thing because they make sense. They're happening with the contraction. The contraction is causing baby's head to be squeezed. It is temporarily cutting off their oxygen supply. And so of course it makes sense that their heart rate would go down when their oxygen supply is being cut off. Now, the good thing is it goes back up during the interval, so during the time in between contractions. That's a good sign. That means everything's going as it should. So when do we expect to see early decelerations? In the transition phase and the second stage, which is the pushing stage of labor. So they make sense. We like earlies. Earlies are totally fine. We expect them. We know. We're watching the monitor and we know mom's getting kind of close. Maybe we just checked her a little bit ago and she was like 8 centimeters or something like that. And you're watching the monitor and you start seeing her throw these earlies. That's a sign like, oh, maybe baby's head is down. Maybe she's ready to start pushing. So we like earlies. Earlies are okay. So let's talk about the bad guys. We have variable decelerations and late decelerations. Variables are when there's a decrease in fetal heart rate during various phases of the contraction. So remember, our earlies, our good ones, the ones that made sense, they went down when the contraction went up. They mirrored each other. Those made sense. Variables, they vary. They kind of just go whenever they want. Kind of all over the place. There's no real pattern to them. They're kind of crazy. So that's variables. They vary. What's causing variables? Most likely cord compression. Most people have probably heard of somebody who's, had a baby that had what's called a nuchal cord, or a cord around the neck. Cord compression, that's what that is, okay? It's actually very common. So when we see variable decelerations, we don't freak out right away. We try to solve the problem. So what are some things the nurse can do about it? Turn mom to her left side. Give her oxygen. If this variable is being caused because mom is hypotensive, we can give fluids. Sometimes that happens. Sometimes mom gets the epidural and the epidural works just a little too well and it makes mom hypotensive and her blood pressure just kind of tanks. And with her blood pressure going down, baby's heart rate also goes down. So if that's the case, then we'll give fluids. If it's caused by oligohydramnios, which is not enough amniotic fluid, we're going to call doctor and we're going to expect them to order an amnioinfusion. So an amnioinfusion is when we, the nurse, instill warm normal saline using machine. We'll have a little machine for it. We instill warm normal saline into mom's uterine cavity to kind of ease that pressure on the cord on the baby. So what do variables look like? They look varied. They look all over the place. So like I did before, I drew my little dots down. So you can see where they are hitting in relation to the contraction. So the start of the variable deceleration on this one kind of starts during the peak, during the acme. On this one it starts during the increment. On this one it starts a little bit between the increment and the acme. So they're kind of all over the place. That's variable decelerations. Like I said before, variable decelerations, cord around the neck, cord compression, pretty common, so we don't freak out about them right away. We watch them, we're a little bit suspicious of them, but we don't freak out. If they're happening for a long period of time and our interventions haven't really done anything to stop them, that's when we start to get concerned and start thinking, okay, we need to deliver this baby or we need to think of something else. So late decelerations, these are the real bad guys. These are the ones we never want to have. So what happens with late decelerations is they start after the contraction has already started, and then they end after the contraction has already ended. So that doesn't make sense, right? Our earlies made sense because they start with the contraction, they end with the contraction, baby's head's being smushed, it makes sense. Lates don't make any darn sense, right? Because they're starting, if you see on my drawing here where I did my little dots, they're starting during like the middle, usually during the peak of the contraction, and then they keep going during the interval. So when they should be resting, baby should be getting oxygenated during these interval periods, it's not, okay? Its heart rate is still going down. So that's bad, right? So what's usually the cause of late decelerations? UPI, uteroplacental insufficiency. So you got a bad placenta. Something's going on with your placenta. So what are some things that can cause UPI? So mom can have a hypertension. It could be chronic hypertension, gestational hypertension, or even a preeclampsia. What happens with those is mom's not getting enough blood flow to the placenta, so therefore baby's not getting enough oxygen. Or she could be post-dates, so she could be past her due date. The placenta is only meant to last for so long, and after a while it starts to calcify and break down, and it doesn't work as well. So this could be an overdue baby, so the placenta is not working as well. So these are some things that can cause late decelerations. So what do we do about it? We'll turn mom to her left side to optimize placenta blood flow. We'll give 10 liters of oxygen via face mask. Monitor her blood pressure. If blood pressure is our problem, right, we want to make sure it doesn't get dangerously high. If she's getting Pitocin, so if she's being induced or augmented and we're giving her IV oxytocin, which is called Pitocin, turn it off, because we don't need to be stressing out her body anymore right now, stressing out baby, so turn off that Pitocin for now. And then we're definitely going to call the doctor. This usually turns into an emergency situation. I said with the variables that they're pretty common. They're not good, but they're common, and we kind of keep an eye on them and let's see what happens. We don't wait and see what happens when it comes to lates. This baby has to come out pretty darn soon if you're having lates. So here's my little drawing for lates. So as you can see, they start at the peak or the acme of a contraction, and they continue to go even after the contraction is over. So that's not good. So baby is not getting oxygenated during these intervals like they should be. So that's bad, that's dangerous. So lates, never good. So I know that's a lot of information I just gave you, but there is a helpful little tool for you to remember these things. So the helpful tool that we use to remember the difference between earlies, lates, and variables is veal chop. So these line up with each other. So V is for variables. What causes variables? Cord compression. E is for early decelerations. Those are the good ones. Those are the ones that make sense. What causes earlies? Head compression. Acelerations, we like those. That means baby's moving around. We're not worried about those at all. So those are okay. And then late decelerations are usually caused by placental problems. So something's going on with the placenta. It's not working very well. It's causing late decelerations. The last thing I wanted to touch on were the fetal heart rate categories. So all fetal heart rates, good, bad, and in between, can be broken up into 3 different categories. So the first one is normal. So that's the good ones. So in a normal category, baby has to be between 110 and 160. Moderate variability, so good squiggles. No late or variable decelerations present. And they may or may not have early decelerations. If they don't have them, that's fine. If they do have them, that's fine too, because they're normal. Our second category is indeterminate. So it's not necessarily normal nor abnormal, so it's kind of in between. Some examples of what this could be would be minimal variability. So we do have some squiggles, they're just like little squiggles like this, okay? Or we have no variability, it's absent, it's a flat line, but there's no decelerations. So some reasons babies might have some absent variability, but it still be okay, is baby sleeping, right? So babies sleep in the womb, they have sleep cycles, and when they do that, they can have some absent variability. Or maybe you just gave mom some sort of narcotic, like a morphine or a Dilaudid or something like that. So mom got that to help with her labor pain, but it really decreased baby's heart rate. We expect that. So if you just did an intervention like that and then you see baby goes down like this and gets a little flat, you don't really need to freak out too much because you know, oh yes, that's why that's happening. You can explain why it happened. If it lasts for too long, then we're worried about it, but at least you know why it happened. And then the other example could be no decelerations after fetal stimulation. So remember, our decelerations were our good guys. They're the increase of 15 by 15. Usually what happens is you do like a vaginal exam, you press baby on the head and they react, or you do the vibroacoustic stimulation and you kind of buzz them and they react. So in this instance, you're doing those things, you're bothering the baby, and they don't care. They're not reacting. They're still having good, variability. Their heart rate's still in a normal range. They're just not having any decelerations. And then the final one, the bad one, the abnormal one, is category 3. So category 3, you have to have absent variability, so a flat line, and one of these other things. So you can have absent variability and recurrent lates, so absent variability and multiple late decelerations, absent variability and recurrent variable decelerations, or absent variability and fetal bradycardia. Because if you remember from the beginning of the video, bradycardia indicates hypoxia, so lack of oxygen to the baby. So baby's not being variable and they're having a low heart rate under 110. Those are scary signs. Usually to do an emergency C-section, you need to have a category 2 or a category 3. You're not going into that operating room in an emergent situation for a category 1. Category 1 is normal. We like those. Okay, so now let's do some practice ones. Now let's do a practice couple. This first one, I didn't draw the grid because I'm not very good at art and I didn't want it to look confusing for you guys, but we're gonna mimic the grid here. So 80, 150, 120, 90, this is our grid. The first part here, this top part, this is baby's heart rate, and then the bottom portion is mom's contractions. When you look at this, the first thing you wanna see is, well, what's the heart rate? And if you can see, it comes up to here, 150. So we'll answer our question here. What's the heart rate? It's 150. The next thing we want to look at, are there any decelerations present? So any increases above baseline? No, that's not really what's going on. We got some wiggles, but we don't have any obvious hills. No decelerations. Are there any decelerations present? So any dips in the heart rate? Yes, there are. And now what kind of decelerations are these? Let's see, where do they line up? So they start when the contraction starts and they end when the contraction ends. They are mirror images of each other, so these are early decelerations. Is there any variability? So looking at the baseline of baby's heart rate, is it a flat line or are there squiggles? There's squiggles, that's variable, that's a good thing, so that's a yes. And then finally, given all this information, the heart rate of 150, no decels, early decels, and yes to variability, what category is this? 1, 2, or 3? It's 1. Right? Because everything's normal, it's in good range. You may or may not have decels, that's totally fine. And if you have decels, at least they're earlies. Okay, now let's try another one. I did add some things onto our grid. These aren't normally on the grid, but I wanted you to be able to see them. So our first one is, what is our heart rate? If we look here, it's 140. Are there any acelerations present? So any 15 by 15s? Oh yeah, look, there's quite a few. 1, 2, 3. Any decelerations present? So drops from the baseline? No, doesn't look like it. What's the variability here? This is a moderate variability. Look at all this squiggleness, right? So variability, yes. And then knowing all this information, what is our category? Our 1, 2, or 3? This is a 1. This is really good. So baby is happy and good and normal and nothing funky is going on here. This is a really good reading. All right, now check out this one. So our first thing we want to do is identify the heart rate. So 150. Any acelerations present? Nope. Any decelerations present? Nope. What's our variability? Normal, moderate, or a loss of? I would say a loss of, right? Absent variability. And then knowing all of this information, what is our category? This is a category 2. So our heart rate is in a normal range, which is a good thing, right? We don't have any acelerations, but that's okay. But we also don't have any decelerations, and that's good. So baby could be sleepy, or baby could be under the influence of a medication we gave to mom. But this is okay for now. We're gonna keep an eye on it, but it's okay for now. All right, let's take a look at this one. Our heart rate is 150. Are there any acelerations present? Yes, there is one. There's one right here. Are there any decelerations present? Yes, definitely. And then what kind are they? Well, let's line them up. So this one lines up kind of here with the start. This one lines up kind of after that. This one lines up kind of a little bit between the increment and the acme. And this one kind of lines up with the start in the beginning here of the acme and the end here of the increment. So they're kind of all over the place, right? They're not like a nice uniform pattern. These are variables, okay? Because they're kind of all over the place. A good sign is when we have variable decels, they come back up to baseline and then they throw a couple of acelerations in there. So baby realized that they went down and they went back up for a little bit. So that's a good thing. So we're still going to keep an eye on this, but this is variables. So is it variable? Yes. And then what's our category here? Category 2. Because we have this acel, and we have this variability, the squiggliness. Now, if this were a flat line and we didn't have this acel here, then we'd be a little bit more concerned. This would be a category 3 because we could have absent variability with reoccurring variable decels. But since we don't have that, this is still considered a category 2. All right, let's take a look at this one. So what is our heart rate? It's 150. Any acelerations present? No. Any decelerations present? Yes. And now we got to figure out what kind of decels. So these ones are starting, draw our line down, at the peak, also called the acme of the contraction, and they're ending way over here in the interval after the contraction is over. So these are late decelerations. Is there any variability here? Any squiggly lines? No. Look how flat and smooth our line is. That's not good. So no for our variability. And then, given all this information, what category is this? This is a category 3, right? Good. So this is bad. We don't want this pattern on our babies, and we wouldn't let it get to this point, right? If this happens, we would go in, we do all our interventions, we call the doctor, and she might need to deliver this baby. Another thing I wanted to point out about this strip is look at some of these right here. If I can kind of draw a little line. Bam, 90 beats per minute. So this is bradycardic. So not only is this late decelerations, absent variability, there's also bradycardia going on here. So this baby is not well oxygenated, right? Because we're going under our 110, which is our normal low, right? So this is the perfect storm. This is like the worst strip. Actually, let me tell you what the actual worst strip is. A worse than this would be this. We're just going like this. And it just tanks, goes up, and never comes back up. This is a crash section. This is an emergency. This is dangerous stuff right here. So hopefully we don't see that very often. This other one I did right before it, not great either. So I hope you found this video helpful. I know this can be like a really difficult subject for most students. So when you have it on your homework or you have it on an exam or on NCLEX, I want you to first figure out, okay, so what is the heart rate? What is baby's heart rate? Is it between 110 and 160? Are there acelerations, yes or no? Are there decelerations, yes or no? And if they do have decelerations, what type of decelerations are they? What is the variability? So is our line like this or is our line like this? And then finally, using all that information, you can figure out category 1, 2, and 3. Any questions or comments, please let me know. If not, I'll see you on the next one.